Good day, everyone. My name is Sandy Hobson. My student ID is 22195-615. Today, I will be presenting my Assessment 2 case study for Ms. Teresita Manalo. Meet Ms. Manalo. She has a history of atrial fibrillation and was preparing for discharge from the coronary care unit when she was diagnosed with an embolic stroke. To begin with question 1, I will discuss A to E assessment for Ms. Manalo. Let's start with her airway. Her GCS is 12 as shown on table 1 and her speech is slurred, which tells me the airway is currently patent but her reduced consciousness put her at a risk of losing protective reflexes. Stroke Foundation recommend patients with decreased level of consciousness require very close airway monitoring. So my clinical decision here is to have suctioning equipment such as Yankee suckers shown in figure 1 ready and to escalate early if her GCS drops further. Next is breathing. Her respiratory rate is 26 breaths per minute and she's maintaining an oxygen saturation of 95% on 6 liters of oxygen via Hudson mask, an example of which is illustrated in figure 2. Stroke Foundation guidelines recommend we titrate oxygen to keep saturations between 94 and 96%, avoiding unnecessary hyperexia, which can worsen brain injury. Clinderford et al. Clinically, that means I would continue oxygen therapy, reassess frequently, and escalate to advanced support if she shows any signs of deterioration. Ms. Manalo's circulation shows an irregular heart rate of 132 beats per minute, consistent with atrial fibrillation as shown on figure 3, and blood pressure of 170/95. In acute ischemic stroke, this level of hypertension is often permissive to maintain cerebral perfusion. According to the American Heart Association, it becomes an issue if she is a candidate for thrombolysis as systolic blood pressure must be reduced to under 185 before treatment. Bath et al. So my decision making here is guided by her eligibility for reperfusion therapy, making sure her IV access is patent as you can see in figure 4. Continued cardiac monitoring and blood investigations are prioritized. For disability, Ms. Manalo has a GCS of 12, left-sided weakness, and slurred speech showing clear neurological compromise. Her blood glucose level is 5.5, so hypoglycemia is excluded. At bedside, as per Australian Commission on Safety and Quality in Healthcare and Stroke Foundation's guidelines, I would complete a neurological assessment, monitoring GCS, checking pupils, assessing motor strength, speech, cognition, and vital signs, as these changes may signal deterioration. Structured tools such as NIH Stroke Scale or FAST Test as seen in Table 2 can help capture changes consistently. These guide decision making and activating the stroke pathway, arranging urgent CT scans, and escalating care if her status is worsened. Finally, exposure. Her temperature is normal at 36.9, but maintaining normothermia is important because both fever and hypothermia worsens outcomes. Clinderford et al. Given her hemiparesis, she is also at a risk of pressure injuries and aspiration. This means I would keep her nil by mouth until she has a swallow assessment done by a speech pathologist. Implement early pressure area care and position her safely with semifowler's position as shown in figure 5 to reduce intracranial pressure. Moving on to question 2, 4 high priority nursing interventions for Ms. Manalo. Number 1 is aspiration prevention and airway safety. Due to Ms. Manalo's slurred speech and decreased consciousness, she is at a high risk of aspiration. She must remain nil by mouth until a swallowing screen is performed. Be positioned in semifowler's position and have suction equipment available. Oxygen should be titrated to maintain saturation between 94 and 96%. Clinderford et al. These actions prevent aspiration, pneumonia, and hyperexia, which is common post-stroke complications. Next is optimizing cerebral perfusion through blood pressure control. Ms. Manolo's BP is 170/95. For acute ischemic stroke, moderate hypertension is usually tolerated to maintain cerebral perfusion. However, according to the American Heart Association, blood pressure must be closely monitored, managed, and if she receives thrombolysis, systolic blood pressure must remain below 180 to reduce the risk of intracranial hemorrhage. Clinderford et al. Third priority is ongoing neurological and vital signs observation. With a GCS of 12 and left-sided weakness, Ms. Manalo requires a frequent neurological checks using tools such as GCS and NIH stroke scale, alongside with vital signs. As per Stroke Foundation, this enables early detection of deterioration such as cerebral edema, hemorrhagic transformation, which requires urgent escalation. Prevention of pressure injuries and mobility complications. Due to left-sided weakness and reduced consciousness, Ms. Manolo is at a high risk of immobility-related complications, such as pressure injuries, venous thromboembolisms, and muscle contractures. Early nursing interventions, ordering an air mattress, regular repositioning, applying TED stockings, and or use of compression devices as ordered, and collaborating with physiotherapy for early mobilization when safe. These actions reduce secondary complications and promote recovery. For question 3, I will discuss 3 medications relevant to Ms. Manolo's care. For each, I will highlight the key nursing considerations, including what needs to be assessed, how the medication should be safely administered, and potential side effects to be monitored. First medication is heparin IV infusion. When administering heparin IV infusion, I would review baseline coagulation profile including APTT and platelet count, and check for any contraindications such as history of heparin-induced thrombocytopenia, MIMS Australia. I would also monitor for signs of bruising, hematuria, or GI bleeding. In terms of administration, heparin is a high-risk medication. As guided by Southeastern Sydney Local Health District, anticoagulations with intravenous heparin sodium infusion procedure sheet, it must be given via an infusion pump with 2 nurses checking, and the rate is adjusted according to APTT results, checked about 4 to 6 hours after initiation or changes. I would also ensure the IV line is patent for infusion. The key side effects I would watch for are bleeding, thrombocytopenia, and local site irritation. MIMS Australia. Second medication is Metoprolol 50 mg by daily. For Metoprolol, my assessment focused on her cardiovascular status. I would check her baseline heart rate, blood pressure, and ECG rhythm, while being mindful of contraindications such as bradycardia, heart block, or asthma, as beta blockers may worsen bronchospasms. Therapeutic goods administration. In administration, the drug should be given orally or immediately after food, and tablets must not be crushed. Importantly, I would hold the dose if her heart rate dropped below 60 or her systolic blood pressure is under 100 and escalate to the doctor. Common side effects include bradycardia, hypertension, dizziness, and potential bronchospasms. Third and last medication is Pantoprazole 40 mg daily. For Pantoprazole, I begin assessing the indications, which in this case is likely gastric protection given her anticoagulation therapy, MIMS Australia. I would confirm there are no allergies to proton pump inhibitors and review her renal and hepatic functions if long-term therapy is anticipated. Administration should be once daily, ideally in the morning at least 30 minutes before food, and tablets should not be crushed or chewed. I would educate Ms. Manalo to report any headaches, abdominal pain, or diarrhea over longer courses. I would also be aware of risks such as vitamin B12 deficiency or osteoporosis-related fractures. MIMS Australia. In conclusion, Ms. Manolo's case shows how the A to E assessment guides timely stroke care and decision making by focusing on aspiration prevention, blood pressure control, neurological monitoring, and pressure area care, we can reduce complications and support recovery. Safe use of medicines like heparin, metoprolol, and pantoprazole further highlights the role of evidence-based nursing care in improving outcomes. Thank you all for watching my presentation and your time.